let's start with tubular defects. Renal tubules, as you know, are responsible for fine-tuning of the glomerular filtrate to reabsorb most of water, most of sodium, bicarb, calcium, magnesium, phosphorus. And so this maintains a fluid balance, electrolyte balance, and the acid-base balance. Okay, based on the sodium delivery to renal tubules, the tubules have the priority to keep sodium, to reabsorb sodium to the plasma in exchange for potassium and hydrogen. So potassium and hydrogen are excreted in the renal tubules here in the urine in exchange for sodium. Okay, so the kidney usually has priorities. It's priority number one to concentrate the urine to maintain specific gravity of urine within normal. Okay, number two, it has a priority to keep sodium. Okay, at the expense of potassium or hydrogen. It has a priority to keep the acid-base balance. So in case of loss of bicarb, chloride will be reabsorbed maximally. In case of alkalosis, on the other hand, and increased bicarb levels, so chloride will be excreted. Okay, it has a priority to acidify urine. Okay, acidification of urine is one of the important functions of renal tubules, where hydrogen ions are secreted as with ammonia, okay, as ammonium chloride in the urine. So keep the pH of urine acidic between 4.5 and 5.5. Okay, so in the proximal tubules, about 70 to 80% of water and the sodium will be absorbed. In the lobe of Henle, about 10 to 20% of water and the sodium will be reabsorbed, to be continued in the distal convoluted tubule, 5 to 10%, and in collecting ducts, 2 to 5% of sodium will be reabsorbed. We have the main cations, okay, in the form of sodium, potassium, hydrogen, okay, while the main anions are in the form of chloride and bicarb. We calculate what's called the anion gap by subtracting the sum of anions, chloride and bicarb, from the sum of cations, which are sodium and potassium. As you know, there are anions present in the plasma that can't be measured. For this, it results in a normal gap between the sum of cations and the sum of anions. This gap is normally between 8 and 16. It usually considered high if it is more than 20. Okay, so these are the main functions of, or the fine-tuning functions of renal tubules. So to know, okay, that here lobe of Henle, furosemide works or functions here on the sodium potassium chloride transporter here. Okay, this is the site of action of furosemide, resulting in increased excretion of sodium, water, and potassium in urine, associated with dehydration, associated with alkalosis, okay, due to reabsorption of bicarb caused by increased loss of sodium chloride, okay, and associated with hypokalemia. The same effect can be seen in Porter syndrome, where it is caused by a tubular defect, lies here in the lobe of Henle in the same transporter. Okay, so also it is associated with alkalosis due to maximal reabsorption of bicarb and loss of sodium chloride, okay, with the compensatory getting rid of potassium, so severe hypokalemia, plus increased calcium excretion in urine in Porter syndrome, which occurs also with loop diuretic furosemide. Here in the distal convoluted tubules, we have thiazide diuretic working here on the sodium potassium hydrogen transporter, also increasing sodium and water excretion. But to know it has a paradoxical effect through reduction of urine output rather than increasing urine output as a diuretic. Another paradoxical effect is the reduction of calcium excretion in urine. So here works thiazide, okay, and on the same transporter we have a mutation defect result in the Gentleman syndrome. Gentleman, which is a variant of Bartter syndrome associated also with excess loss of sodium and water, so present with polyuria. And to retain sodium, kidney will get rid of potassium to keep sodium. So there is also hypokalemia, but there is no increase in calcium excretion in urine in Gentleman. Also, there is increased magnesium excretion in urine in Gentleman. Okay. Also here in the collecting ducts we have two hormones functioning here. We have the antidiuretic hormone and aldosterone. Antidiuretic hormone has its receptors on collecting ducts, so function to keep or to maintain water balance, to reabsorb water. Its secretion will be increased of hypovolemia and dehydration. The other hormone is aldosterone. Aldosterone works by sodium and water retention and increase potassium excretion. As a competitive effect with aldosterone on aldosterone receptor, spironolactone, the weakest diuretic, function by blocking aldosterone, competitive inhibition with aldosterone on its receptors, so it will be associated with minimal diuretic effects through increased sodium and water retention, but the beneficial effect of hyperkalemia, potassium retention. So usually spironolactone is combined with other loop diuretic like furosemide or thiazide to avoid their side effect of hypokalemia. If you have an adolescent boy complains of malaise, inability to take part in sports as he becomes tired easily, his blood pressure is normal and his labs show that he has sodium on the upper borderline, potassium is low, chloride normal, bicarb high, magnesium low, renin, okay, or plasma renin activity. He may give you plasma renin activity or renin. Okay, and here he has high renin. Aldosterone also is high, glucose is normal, and urea is normal. So what is the most possible diagnosis? Is it Bartter-Liddle syndrome, Gentleman chronic fatigue syndrome, or hypokalemic periodic paralysis? So to continue and to get back to our question, when reviewing the tubular defects, starting with proximal tubules, we have cystinuria. Cystinuria, as we have mentioned, is autosomal recessive defect in the proximal tubule, resulting in defective reabsorption of the cool amino acid, which are cysteine, ornithine, arginine, lysine. The most important of these is cysteine. Increased loss of cysteine in renal tubules will result in recurrent stone formation, which are hard and opaque. So treatment would be by hyperhydration and alkalinization of urine. The second tubular defect in proximal tubule is the X-linked hypophosphatemic rickets. Is an important area of questions where we have a hereditary mutation, okay, that is X-linked dominant. Okay, so we need just one X chromosome to carry the defective gene to show the disease, and so it can present in either male and female and run in families like this in a vertical pattern. Okay, it is X-linked dominant mutation. So we have mutation in the phosphate regulating endopeptidase gene or FIX gene. Okay, and this will result in defective phosphorus reabsorption in the proximal tubule. You know, most of phosphorus is reabsorbed in the proximal tubule. So now we have what's called low TRB or tubular reabsorption of phosphorus. By this we can calculate the amount of phosphorus loss in urine. Okay, so we have high phosphorus excretion in urine and low tubular reabsorption of phosphate, resulting in hypophosphatemia. Hypophosphatemia will be associated rapidly with increased alkaline phosphatase activity. On the other hand, we have normal parathormone and calcitriol levels. You know, parathormone has its main priority to keep ionized calcium level within normal. It's not concerned with phosphorus levels. Okay, so having hypophosphatemia with high parathormone, this indicates we have hyperparathyroidism that is complicated by hypophosphatemia. But if we have hypophosphatemia with normal parathormone level, this means the primary defect in the phosphorus level, okay, not in parathormone gland, parathyroid gland. Okay, so the defect here is in the tubular reabsorption of phosphorus. So how it present by 12 months age, the child will present with delayed milestones, delayed growth and delayed dentition. Then rickets will appear with all its manifestations and recurrent dental abscesses. Okay, so we have rickets. Rickets discussed in details in the chapter of endocrinology, and you know that it results from defective mineralization of bones. It has many causes, okay, that include calciopenic rickets. It's caused by calcium deficiency, or phosphopenic rickets due to phosphorus deficiency. As you know, bone is formed of protein, okay, and cartilage and minerals. These minerals include calcium and phosphorus. Okay, so hypophosphatemia will be associated with all manifestations of rickets, and here in this disease, okay, which is called the vitamin D resistant rickets or X-linked hypophosphatemic rickets, the defect in the renal tubular reabsorption of phosphorus. There is no problem with the vitamin D levels, and there is no problem with calcium levels or parathormone levels. So the treatment of this condition will be by alpha-calcidol, the active form of vitamin D, despite we don't have a problem with it, but we need high doses of vitamin D to compensate for the low phosphorus level. Vitamin D function on the gut, on the kidney, okay, to elevate phosphorus levels. Also, it functions on bone by mineralization of bone with phosphorus. So we need active form of vitamin D, either alpha-calcidol or calcitriol, plus oral phosphate supplements. Monitoring for hypercalciuria and nephrocalcinosis, don't miss that. Any patient receiving vitamin D or calcium therapy for long times should be followed for the risk of increased calcium excretion in urine and nephrocalcinosis that can progress into end-stage renal disease. So these patients can be a boy, can be a girl. They have short stature. They have deformities in bone due to weight bearing on the weak bones, may have even pathological fractures, and they have rickets. There is defective healing of the epiphyseal line as the disease presents since infancy and during the growth of epiphyseal plate before its fusion, okay, and all other manifestations that will be discussed in the chapter of endocrinology can present. Being a hereditary condition, so it is not uncommon to find a mother or a father presenting with his siblings who may be a boy or girl. Both are okay, the parent and his child, both are short and having deformities and suffering from rachitic manifestations. Okay. Then to another tubular defect, which are the renal tubular acidosis. Renal tubular acidosis, okay, which affects the renal tubules, result in the hyperchloremic metabolic acidosis with normal anion gap. We have 4 types of RTA or renal tubular acidosis, 1, 2, 3, and 4. They are named after the order of their discovery, okay, and they are not related to each other. Each defect is by its own, it is not related to the other defects. Okay, very important. Type 2, remember to the proximal RTA, defect in proximal tubules. Type 1 refer to distal RTA, defect in the distal tubule. Type 3 is a mix between both, and the type 4 is referring to any condition associated with aldosterone deficiency, either deficient level of aldosterone or resistance to its function. So it is the only type of RTA that is associated with hyperkalemia, okay, due to missing the aldosterone action, okay. And so let's revise them one by one. So either in type 2, which is the proximal RTA, the defect mainly in the bicarb reabsorption in proximal tubule, and the proximal tubule being the most important part for reabsorption of bicarb, so large amounts of bicarb are lost and associated with severe metabolic acidosis. On the other hand, type 1 or distal RTA is caused by different mutation that is associated with impaired acidification of urine, okay, due to defect in the hydrogen potassium transporter defect. We have said one of main priorities of the kidney to acidify urine through hydrogen secretion into urine, into the renal tubule as ammonium chloride to keep the urine pH acidic. Loss of this function is present in the distal RTA, and so it presents with alkaline urine, and even we cannot acidify urine by ammonium chloride load, and this is an area of question, and it is a way to differentiate between having proximal or distal RTA is the IV ammonium chloride low. In case of the urine become acidified after ammonium chloride infusion, this means we have proximal RTA. In case of failure to acidify urine after the ammonium chloride infusion, it is distal RTA. Both are associated with metabolic acidosis that is of normal anion gap, because we don't lose bicarb, okay, we lose bicarb rather than addition of acidic load, so it is normal anion gap, metabolic acidosis associated with hyperchloremia, okay, to compensate for the bicarb loss. Both distal and the proximal RTA are associated with hyperchloremic normal anion gap metabolic acidosis, but logically type 2 is more severe because the defect in proximal rather than in distal RTA, okay, and so will require a higher amount of bicarb replacement. Both are associated with polyuria and associated with dehydration and associated with growth failure and so on, so we need to differentiate between both. Type 3 is combination of type 1 and type 2. Type 4 is caused by hypoaldosteronism or aldosterone resistance. Again, the four types are not related to each other. Each one is caused by a different mutation. So we have different pathologies, okay, and these can be inherited and so will present in infancy. RTA can be an inherited mutation presenting in infancy with the polyuria, okay, with the failure to thrive and with the attacks of dehydration. Any dehydration will be associated with vomiting, associated with constipation, associated with some fever, okay. So it can be inherited or it can be acquired that develop at any age. Any insult to the renal tubule will result in defective function and they can present with bicarb loss and the renal tubular acidosis, okay, non-anion gap, hyperchloremic metabolic acidosis, and otherwise well-functioning kidney. We usually have normal urea and creatinine levels. This is very important. In general, RTA is not a common presentation, but should be in mind and should understand its pathology and its presentation. To revise, distal RTA or type 1 is caused by impaired acidification. The pH of urine will be more than 5.5, associated with hypokalemia. We lose potassium in urine here to keep sodium, okay, due to excess sodium bicarb loss. So potassium will be excreted in exchange of sodium. So we have hypokalemia that is less severe than the proximal RTA. Okay, we have hypercalciuria here, and this is a differentiating feature between proximal and the distal RTA. In distal RTA, we have increased the calcium excretion in urine, and this shows a risk of renal stone formation and the nephrocalcinosis. Proximal RTA, no. Rickets okay, will be associated. Why we have rickets? Number one, we have hypercalciuria. Number two, we have vomiting and anorexia due to the attacks of dehydration. Number three, we have acidosis, and acidosis usually compensated by release of calcium carbonate from bone. And so this will present by rickets if the condition is inherited and presented during infancy. We have poor growth for the same reasons. We have poor appetite, we have dehydration and vomiting. We have vomiting, polyuria, and dehydration, and this is the presenting scenario. Usually an infant who is dehydrated, who is polyuric, has persistent vomiting, has constipation, and you will diagnose the condition when you do your biochemical lab test to find that he has blood gas showing metabolic acidosis, and you will calculate the anion gap to find it normal anion gap metabolic acidosis. Chloride levels will be high, so this is the characteristic metabolic disturbance in case of RTA, plus exclusion of other causes of the same condition. Okay, so you can calculate the urine anion gap, which get also the difference between cations and anions secreted in urine, and you will get the characteristic features of electrolyte and bicarb loss in the urine. Urine anion gap plus plasma anion gap, blood gas, and electrolyte levels plus the clinical presentation. This is how we diagnose RTA. So it can be acquired in case of medication use like cyclosporin, which is nephrotoxic, amphotericin, it is antifungal medication and it is nephrotoxic. Also other toxins like gold, like lead. Obstructive uropathy, so if you have persistent obstruction to the urine flow, as we have discussed in the congenital anomalies, so this can be complicated later on by tubular defect and appearance of the renal tubular acidosis. It can be inherited, where association of these renal manifestations with inner ear dysfunction and the sensory neural hearing loss is characteristic, and can be noticed to have both combination of sensory neural hearing loss and distal RTA due to the inherited mutation in pump function. Okay, so remember, you have association of sensory neural hearing loss with thyroiditis in Bender syndrome. You have association of sensory neural hearing loss with nephritis in Albert syndrome, and now you have another association of sensory neural hearing loss with distal RTA. All are caused by hereditary mutations. The treatment here is with by supplementation of fluid for the dehydration, supplementation with potassium for the hypokalemia, oral supplementation with sodium chloride for the sodium loss in urine, and supplementation with bicarb, sodium bicarb, oral solutions in a dose of 1 to 2 millimole per kg per day for the treatment of acidosis. RTA2 or proximal RTA, we have defective bicarb reabsorption by the proximal tubule, so the same presentation but will be more severe. So an infant presenting with attacks of polyuria, polydipsia, complicated by dehydration, and this will be complicated by vomiting, constipation, and maybe the dehydration fever. Anorexia, failure to thrive, growth failure, okay, very important. We have here intact acidification of urine. So ammonium chloride loading will result in acidification of urine. This is important for differentiation from distal RTA. Nephrocalcinosis is not a feature here. Calcium salts are soluble in acid urine, and so we don't have nephrocalcinosis or hypercalciuria in proximal RTA. Here is the treatment will be by large doses of alkali supplementation due to excessive loss of bicarb, and also it can be isolated inherited mutations. This is rare to have just isolated proximal RTA as inherited mutation, but the most common presentation for proximal RTA will be a part of the Fanconi syndrome. Again, it can be an acquired mutation, acquired defect by tubular insults. The treatment here will be with high amounts of bicarb supplementation plus fluid and potassium supplementation. So what is Fanconi syndrome? Fanconi syndrome, it is a generalized proximal tubule reabsorption defect. It is not just bicarb loss, but we lose amino acid. There is amino aciduria. We lose glucose. We have glucosuria, but characteristically with normal blood glucose. We don't have diabetes. We don't have hyperglycemia or hypoglycemia, but we have glucosuria. Okay, so glucosuria, amino aciduria. We lose also phosphate in excessive amounts. There is hypophosphatemia and low TRB or tubular reabsorption of phosphates that will be complicated by rickets, or rickety manifestations will be present. We lose bicarb from proximal tubule, so RTA type 1, the same presentation of the hyperchloremic normal anion gap metabolic acidosis that is associated with severe hypokalemia, okay, and the attacks of polyuria, polydipsia, dehydration, vomiting, constipation, failure to thrive, and all of this. We have severe hypokalemia, we lose potassium, okay, and also the kidney compensate for the sodium reabsorption by potassium loss, we have mentioned, okay. Sodium, calcium, magnesium concentrations can be affected in Fanconi syndrome. An infant or maybe older child, if the cause is acquired, present to you with these again: polyuria, polydipsia, dehydration, sodium depletion, non-anion gap, hyperchloremic metabolic acidosis, faltering growth, and rickets. Again, the cause can be idiopathic or can be inherited, present at early in the early infancy and the childhood years, or can be acquired in case of heavy metal poisoning like iron, like lead, okay, gold. So also drugs and toxins, some drugs like cyclosporin, like amphotericin, aminoglycosides. So nephrotoxic medications can be complicated by Fanconi syndrome, okay, or proximal RTA or distal RTA, and the cause can be idiopathic or can be secondary to inborn error of metabolism. Any inborn error of metabolism that will be associated with the storage of some material, okay, can show its manifestations in the renal tubules, as renal tubules are one of the most metabolically active cells in the body, and they also, and for this they are highly vulnerable for vascular insults like hypoxemia, hypovolemia, okay, and also they are vulnerable for the inborn errors of metabolism. So cases of cystinosis, okay, accumulation of cysteine intracellular, glycogen storage, accumulation of glycogen intracellular, Lowy syndrome, or what's called oculocerebrorenal dystrophy. Remember this, okay, galactosemia, accumulation of galactose, fructose intolerance, accumulation of fructose, tyrosinemia, accumulation of tyrosine, Wilson disease, accumulation of copper. So all these will be stored in the renal tubules and present with Fanconi syndrome. Okay, so the treatment for Fanconi syndrome will by treatment of the cause. This is very important. Okay, removal of toxins, and to treat each defect appropriately. Maybe will with phosphate supplementation for the hypophosphatemia plus vitamin D. Okay, active form of vitamin D like alpha calcidol and calcitriol. It will be by fluid supplementation for the dehydration, maintaining electrolyte balance as regard to sodium, potassium, calcium, magnesium, okay. Also to give the IV bicarb followed by the oral bicarb solution to compensate the proximal RTA, to maintain proper nutrition, okay. And usually the amino aciduria here doesn't present with significant clinical presentation. Also for glucosuria, the important is the hypophosphatemia and the metabolic acidosis, okay, due to loss of bicarb.